Have we started?
Yeah.
Okay, so good evening, everyone, and welcome to Urology Part 1. This is me, Dr. Mohammed, one of the F2s in KSS.
And my name's Hannah. I'm also an F2 in KSS.
Fantastic. So, today's teaching is on urology. It's primarily theoretical. This is the first session, and tomorrow at the same time we'll have Part 2, where hopefully we'll go through some cases. So we're just going to get straight into it, and primarily discussing, things that you might see on the ward as a junior doctor, but also relevant to any medical students that might be joining us. So first things first, one of the key presentations is hematuria, of course. And it's important to note that hematuria is categorized as microscopic or macroscopic, sometimes referred to as non-visible or visible hematuria. Now, of course, no one will present to you with microscopic or non-visible hematuria because they simply can't see it. So it will never be a presenting complaint as such, but it could be something incidental that you pick up while someone presents for something else. And you pick that up by using through a urine dip, where you'd find blood on the urine dip. Macroscopic, of course, visible hematuria, that is a concerning sign that people may present with, and that can be the presenting complaint in and of itself. So, what to ask people when they come in with hematuria? Number one, are they on any anticoagulation or antiplatelets? This is really important to ask. Of course, there's many different causes of hematuria. As you'll be aware, it could be something malignant, so a cancer in the bladder, or in fact anywhere in the urinary tract all the way up to the kidneys. It could be trauma. It could be trauma following catheterization. It could be a UTI or cystitis, whatever it may be. But one obvious cause as well is the patient is on anticoagulation, and as we know, a risk factor for medications such as DOACs and warfarin and whatnot is bleeding, and that can sometimes be bleeding from the urinary tract. So ask them if they're on one of these. This is really important. Something that you also want to check is their hemoglobin trend. So has there been a shift in hemoglobin? And that gives you an indication as to how long they've been bleeding for and how bad that bleed is. And this is, of course, really important because someone may have, what's referred to as rosé hematuria, which is fairly light. It looks like rosé wine or diluted squash. But that could be something that's just been going on consistently for a long time. And so you want to know what the patient's hemoglobin was at baseline and what it is now. And it's important for those doing OSCEs or even those doctors working on the wards that they always look at baseline. So someone's hemoglobin could in fact be low, but it could have been low for ages. So in that case, it's not really anything too concerning acutely. However, if his baseline was, let's say, 120 and he's coming with a hemoglobin of 80, then that is something very concerning. And the same is true, of course, generally now for creatinine, or even if someone presents with shortness of breath, you want to know what their baseline is and compare to that. It's no use just going off of what they tell you initially. Something else, of course, to note is the patient in retention, or has the bleeding caused clots? Of course, clots can block the urethra, and they put a patient into retention. And at that point, of course, we are concerned because that's something that needs to be addressed acutely. Is the patient coming in post-op? So have they recently had a TURP or a TURBT or any kind of other urological procedure? If so, then of course we know they're at greater risk of bleeding because there's been irritation and potentially damage to those areas, and they've scabbed, and so we can kind of expect to a certain extent for some bleeding to occur. And additionally, you want to take a good general history as well. So their occupation, and of course that's important for if you're considering things like bladder cancer, if they've previously smoked, and if they've had any previous hematuria. Something that should be mentioned as well, you want to categorize their hematuria. So is it rosé or is it frank hematuria? Are there clots or are there not? This is something really important. So what you want to do, you want to make sure that there's a full set of OBS, of course, get their urine output, you want to make sure that a bladder scan is done. And when we say bladder scan, guys, we are talking about a post-void bladder scan. Okay, so there's so many times when you might be referred a patient from A&E and they're telling you, oh no, there's 600 milliliters in their bladder. I've just scanned it. Anyone can have 600 milliliters in their bladder. That's not really of interest. What is interesting is if that 600 milliliters is present even after the patient has tried to void. So we call that a post-void bladder scan. So that's what you want. You want to find out what the post-void bladder volume is, not just the general volume within the bladder. Of course, you want to make sure to take bloods, FBCs, to look at things like hemoglobin, Urinary to look at potential changes in their kidney function, if they're in retention or anything like that. Look at clotting screen, is there INR off the charts? And of course, a group and save if you're going to be thinking about potentially giving this patient blood at any point. And of course, look at their catheter patency. So if they've got a catheter in place, whether it be a long-term catheter or perhaps a catheter was put in A&E, is the catheter patent? Is it draining? If it's not, then they could be in clot retention. And of course, that's very important to be aware of. So when do we admit these patients? When do we accept them? We accept them if it's frank hematuria, not rosé hematuria. If it's frank hematuria, and that hematuria has clotted and caused them to be in clot retention. If there is a significant hemoglobin drop, again, that's something concerning. It shows that they're actively bleeding and they're bleeding a lot as well. And so that's something that needs to be tackled acutely. And of course, if they've come after a recent urological surgery, then it's fair game and they should be admitted for monitoring at least. So you don't need to admit these patients if it's just rosé hematuria, just light hematuria. There's no retention, there's no blockage of the catheter, it's draining fine. Even if there is hematuria, but there's no retention and there's no hemoglobin drop, then they don't necessarily need to come in. They can have a washout in A&E and then be catheterized and sent home. Now, something really, really important, when discharging these patients, whether it be from A&E or if they come up to the ward, any new or unprovoked hematuria, so hematuria for the first time or hematuria that's hasn't got a clear cause like a post-op or whatever, a 2-week wait referral needs to be done. And what will happen in that 2-week wait referral is, number one, a cystoscopy, so imaging of the bladder, and number two, a CT urogram, which helps visualize the entire urinary tract to look for any potential malignancy. And of course, like we mentioned, if they are on any anticoagulation, you want to hold that until the hematuria settles, or roughly for about 3 days. Of course, if there's any questions, then put them into the chat and Hannah will let me know, I'm sure. Okay, moving on, and this is somewhat linked, urinary retention. So for those that are watching the recording, I want you to pause now and try and define urinary retention. Okay, let's say they've continued now. So many people, I'm sure, will say urinary retention is the inability to pass urine from the bladder. But that is not an appropriate definition. Reason being is because someone can still be in urinary retention even though they're passing urine. How so? Well, as long as they are unable to effectively empty the bladder, even if they're urinating, they can end up in urinary retention. So someone could be urinating, in fact, quite frequently, but every time they go to the toilet, they are only, urinating a very small amount, or they're incontinent and they're passing urine into their pad or whatever, but it's not, they're never able to fully empty the bladder. And so, they can still be in urinary retention. So what do you want to ask these patients? Number one, what is the residual volume on catheterization? So once again, we're looking at the post-void residual volume, not the initial volume within the bladder. Is the patient diuresing after catheterization? And we'll look at a post-obstructive diuresis in a bit more detail in just a second. Number two, is there an AKI present? So has, in other words, their urinary retention caused a potential hydronephrosis or hydroureter, and that's caused their kidney functions to tank a little bit. And if you're doing imaging, ultrasound or CT, is there presence of bilateral hydronephrosis? Of course, this is very important. What do you want to check? Of course, kidney function. You want to look for the cause of retention. Is it clot retention? Is it retention due to something obscure like Fowler syndrome? Is it due to an infection? Is it due to another cause? You want to try and figure that out. And of course, you want to do a fluid balance chart and monitor for post-obstructive diuresis. When do you want to admit them? You want to admit them if the urinary retention is, significant, so it's above a liter, and there is an AKI or there's bilateral hydronephrosis present. That will indicate chronic high pressure retention. Of course, if the patient is diuresing, then they need to be sent up to urology and monitored. And of course, if there's clot retention, then they need to be taken in for them to have a washout. You don't need to admit the patient if it's just urinary retention and there's no kidney damage. So last night, I had A&E on my case for a lady with Fowler syndrome, basically a lady who was in urinary retention, and they wanted to refer her to me, but all she needed was a catheter to be put in and then sent home. So you don't need to admit those patients. And remember, guys, urology is not a catheter service. So something important. If they're not diuresing, even if the residual was above a liter, so once they were catheterized, you monitor them for a couple of hours, they're not diuresing, then that's okay. They don't need to be admitted or stay any longer in hospital. And very important, of course, when discharging anyone with urinary retention, that if you're discharging them with a catheter, then you need to make sure that you put in a TWOC referral. So they usually come back, depending on availability, within a week or two to have their catheter removed in hospital. And of course, you want to monitor them after you've catheterized them and they've drained for a good couple of hours at least for any potential diuresis. If there's no diuresis, then they can go home and it's all good. All right, so since we've discussed catheters, I figure it's maybe useful to just look at the different types of catheters. Of course, there's quite a lot, but these are kind of the common ones that you might come across. So these here are the two-way Foley catheters. So these are just the standard catheters. They're made of silicone. I think previously they were made of, well, I can't remember the material, but something that people used to get allergic to, so they stopped making them. But anyway, so yeah, they're two-way. Of course, there's one port which is an inlet. Well, it's an outlet really, but can actually be used for an inlet. So that's just where the main port is, where the urine drains, and the area that's colored, so in pink, blue, green, red, or purple, is where you blow up the balloon. Okay, so after you've inserted the catheter, you inflate the balloon, and that just helps to secure it within the bladder so that it doesn't fall out. And indications for a two-way catheter include just urinary retention, pretty much. So if someone's in retention, or you want to monitor urine output for other reasons, so for medical reasons, let's say someone's septic or has an exacerbation of their heart failure or whatever, you can put one of these in, and they come in different sizes, and these colors represent these various sizes. What we have here is something called a Tiemann tip catheter. So it's exactly the same as the one on top, the two-way, but the only difference is that it's got a bit of an angled end to it. And the reason behind that is sometimes it's difficult to catheterize, particularly males with enlarged prostates, or perhaps they have got prostate cancer or BPH, whatever. So for those individuals, that catheter just allows, that tip allows catheterization to be a bit more smooth, particularly when passing through the prostatic urethra. So it's just, it can be handy if you're struggling to catheterize someone with a standard two-way Foley catheter. This, of course, is a three-way catheter, so it's now got 3 ports. So there's an inlet, an outlet, and of course the area in which the balloon is inflated. So the reason why you'd put a 3-way in is because of clot retention, potentially. So you someone's got hematuria, that blood has now congealed and clotted up, and it's now causing retention. The way to manage that is through bladder washout and irrigation. So what you would do is, essentially get a 60 ml syringe and fill it up with normal saline, and connecting it to the inlet, flush the bladder. That pressure that the water is passed through into the bladder should help break down the clot, and then you should hopefully get the drainage of the clot and the remaining urine out of the outlet. You do that several times, and then if you're concerned that the patient is still bleeding and as such would inevitably clot again, then you connect them up to irrigation, again using the inlet. So this is handy, and if any of you do a urology job, you'll use this a lot. This is a suprapubic catheter. So again, it's no different actually to the standard two ways, but instead of going through the urethra, it goes through a port in terms of in the suprapubic region. Now, indications for a suprapubic catheter is basically, think about it, you can't go through the urethra for various reasons. So perhaps there's been trauma to the site, perhaps the urethral meatus is inaccessible, so in some hypospadias, or so recently there was a patient on the ward who had quite aggressive penile cancer, and the tumor was basically blocking up and had covered his urethral meatus, so we couldn't find it. So he was a candidate for suprapubic catheter. Sometimes this is also used in patients with Fowler syndrome, or where urethral catheters are just not an option for one reason or another. And finally, you may or may not see this. It's not too common. Condom catheter, sometimes referred to as Convene. I think Convene is the brand name. But yeah, sometimes patients are really resistant to being catheterized. They don't like it. It's uncomfortable for them. So we place basically kind of what is like a condom, and it attaches to a catheter bag, and it just sticks to the patient's penis, and they're able to urinate freely, and it collects in the bag. And again, the indication for that, of course, is not going to be retention, because you wouldn't solve retention through that bag. It's primarily for urine output monitoring when the patient doesn't want to be catheterized or is resistant to that for whatever reason, so discomfort or pain or whatever. So those are the main catheters that you might come across, just to be aware. Okay, post-obstructive diuresis, we had mentioned it. What it is a polyuric state in which large amounts of sodium and water are eliminated after the relief of a urinary tract obstruction. So patient was obstructed, and that obstruction is removed, and then suddenly the body goes into overdrive and just starts getting rid of loads of water and electrolytes. It's kind of defined by a urine output of over 200 ml per hour for at least 2 consecutive hours, or alternatively 3 liters or more of urine output over 24 hours. What are the potential causes? Well, like it was mentioned in the definition, it's basically following the relief of a urinary tract obstruction. So you've catheterized a patient that was in urinary retention, or you've inserted a nephrostomy and resolved or caused drainage of the urine in the kidney, or following stenting after ureteric obstruction, or maybe there was a unilateral obstruction in a solitary kidney that was then relieved. So any type of obstruction, really, typically it's just going to be standard urinary retention that you catheterize. But any kind of obstruction that you tackle, the patient can be led into diuresis. How do you manage it? It's simple. You basically just need to monitor the patient, monitor their electrolytes. So either do this twice a day or 3 times a day, and monitor their urine output as well, of course. Any fluids that they do lose or electrolytes, and they need to be replaced for obvious reasons. So if necessary, then that can be done IV via a drip, or it can be done orally if it's not too big of a loss. And then following that, if they have been in diuresis, then you want to observe them for 24 hours before discharging them and being confident that they're okay. Okay, renal stones, something very common that you'll come across again. So something to bear in mind about renal stones, is that often the pain is described to be worse than childbirth. It's very, very, very painful, and you need to be sympathetic with patients that present with renal stones. Don't hold back and don't be stingy in terms of the pain relief that you provide them. It can cause a lot of pain, and it's not a very pleasant one. So try and be gentle with them when they do present. So what do you want to ask? Number one, has there been imaging done? Is there a confirmed stone? You should not be accepting patients under urology with stones unless the imaging has confirmed that there is a presence of stones. So ideally a CTKUB. You want to know where the stone is, how big it is, and if there is any hydronephrosis present, of course. If there's a stone present in the ureter of a solitary kidney, obviously that makes things a lot more important or concerning because you only have one kidney to play around with. Does the patient have a stent already in place? Do they have nephrostomy? Are there signs of infection? So has the patient been feverish? Have they had a urine dip? Is that positive? What are their white cells like? What's their CRP? Where are they at exactly? And the reason why this is important is because these patients can become septic very, very quickly. So if there is any signs of infection or the start of sepsis, you want to get on top of that very, very early. And finally, is their pain controlled with analgesia? If it's not, provide them with that. And of course, what you're going to do is give them appropriate analgesia. So typically we give PR diclofenac along with, of course, oral or IV paracetamol. If they need Oromorph, then give that to them, whatever they need basically to get on top of the pain. Because like I mentioned, it is not very pleasant. When do you want to admit these patients? So if they are infected, so if they're septic, obviously they have to come in, and not just come in, but the reg or consultant need to be made aware very, very quickly. And of course, if the kidney stone is causing obstruction. So again, you've got the duo of hydronephrosis and an AKI, then they need to come in as well. Even if the stone is small, but it's causing significant amount of pain, then that's a totally valid reason to admit the patient. They're in a lot of pain. The pain has not settled since they presented to A&E. Then that alone is enough to admit them, to just monitor them for 24 hours, see if they pass the stone, and just make sure their pain is under control. And of course, like we said, if the patient has just the one kidney, then it's important that they're monitored closely, because if anything does go wrong, if it becomes obstructed or they become, infected, then of course it's a lot more concerning because it's just the one kidney that they have. What do you want to do or check? You want to make sure that you've done bloods. So again, kidney function, CRP, FBCs to look at white cells. Is there IV access? Remember, you want to, if you're thinking about operating on this patient to remove the stone, then they need to be made nil by mouth. And of course, that means they need to have fluids running overnight. Have you given NSAIDs? So have you given PR diclofenac? Have you given appropriate analgesia? If there is an infection suspected, then make sure you do a urine dip and an overall sepsis screen if you're worried about that. You don't need to admit the patient if there's no signs of infection. Okay. If they're not in any pain, okay, if it's just an incident, so someone, again, and this is where it's important to make sure that you get a very good handover from A&E, because the patient could be coming in with, I don't know, calf pain or a new rash on their arm or shortness of breath or whatever. They do a scan and they incidentally find a stone, and suddenly they become a urology patient. That patient should not be accepted, especially if it's not causing them any pain and there's no signs of infection. And almost certainly if the stone is 5 millimeters or below and is likely to pass. But like I said, however, even if the stone is below that size, so it's even if it's a 4 millimeter stone, but they're in a lot of pain or they've got a positive urine dip, then they should be admitted. So after you've operated on them, or they've passed the stone, or you've got on top of their pain control and they've been able to go home, then make sure that when you discharge them, you refer them back to the renal colic pathway. So just make sure that they're followed up, and we know what's happened with their stone. Have they been able to pass it, or what's happened? And this is important as well, because typically these patients will be repeat presenters with further stones at different points in their life. Make sure, if it's a small stone and you're happy that their pain is controlled and you think that their stone will pass, that you give them the appropriate pain relief to make sure that their pain is controlled within the community, and also tamsulosin to help aid that stone passing from the ureter. And of course, it's very important to safety net them. So tell them if their pain gets worse, if they develop a fever, any of these things, they need to present back quickly. And we'd likely need to operate on them urgently in seaport or whatever. Okay. So I'll pass it.
Okay, I'm now going to move on to some testicular pathologies. Just to answer a question in the chat about convenes or condom catheters, they're a continence aid, and yes, they are more likely to leak. It depends a lot on, is the size appropriate, and how much incontinence is there, because quite often moisture around the area, it will become less sticky and they will often fall off, or patients will pull them off. So in short, yeah, they are more likely to leak. All right, so testicular torsion, obviously sort of the king of urological emergencies, and a pathology that should always be in the back of your minds in any male presenting with scrotal pain, but also something to think about in just simply abdominal pain, particularly in younger boys, because that can be the kind of sole early sign of testicular torsion, which then progresses to scrotal pain. So always think about doing a genitourinary exam if there is abdominal pain and you've got any kind of index of suspicion. So the key thing here is recognizing it early and referring early so that they can have an exploration, because when the testicle is torted, obviously it becomes ischemic and you can lose the testicle. So in terms of what you would ask about in your history, it's important to get an idea of the onset and the pattern of the pain. So, was it sudden onset or was it a slow onset? Sudden onset will send you more down the torsion route. And often they will be in quite excruciating pain at the time of presentation. When you examine the testis, it can be firm, there can be some swelling, it might be elevated, it might also not be, and that's also described as a high riding testicle, if any of you have heard it in that context. In terms of the shape, you might notice the testis has a horizontal lie. Again, a lot of these signs, they're not always present, or they can be present without it being a torsion, but it's just, one of a few things you can use to aid your diagnosis. A lot of it will be from the history. The cremasteric reflex, so that's a physiological reflex where when you stroke the medial thigh, the testis elevates a little bit, and that can be absent in torsion, and it's quite a strong indicator for torsion. But again, it's not always present in torsion. A lot of patients with torsion will have an underlying deformity called a bell clapper deformity. So it's not something that they would necessarily pick up on earlier in life, but what it is when the tunica vaginalis has an abnormally high attachment to the spermatic cord, it essentially predisposes people to an intravaginal torsion. which is the most common type of torsion in anyone who's not a neonate. The bell clapper deformity is bilateral, which is important when we come to talking about the management of testicular torsion. The blue dot sign, so that's a useful one for essentially distinguishing torsion of the whole testis from torsion of the testicular appendage, which is an embryological remnant that comes off of the testis. It's also called the hydatid of Morgagni. So the blue dot is literally, it's a small blue dot on the testis, which is just that ischemic torted appendage. And that is a different pathology, which is also very painful, but doesn't require surgical management and is kind of the conservative management. Even if you think that this is kind of for people working in A&E, even if you do think it's torted appendage rather than a torsion, still ask the urologist to come and have a look because, it could still be torsion just because there is a blue dot there. And then a final sign that would help to distinguish a painful testis caused by torsion versus something like Epididymo-orchitis is Pren sign, Prehn, where essentially, so a positive Pren sign is when you elevate the testis, does the pain improve? It would be positive in Epididymo-orchitis, but it would be negative in testicular torsion. So basically, elevation isn't going to help the pain; it will still be there. So if you're suspecting torsion, what you need to be doing is be prepping them for theatre. So make them nil by mouth, inform your on-call reg. So if you're working in urology, you want to let the reg know, let the consultant know, because this will be, so CPOD is the kind of emergency list in theatre. They would be going onto the CPOD list for an exploration. Different trusts have different guidelines about who goes for an exploration versus having a scrotal ultrasound, for example. But the kind of the most common gold standard is that anyone where torsion is suspected should be having an exploration. An ultrasound can be used where there's maybe some what's it called, ambiguity, but often ultrasound will cause a delay because of availability, etc. So if it's going to cause it, basically you shouldn't be delaying treatment to wait for an ultrasound. So let's say your patient has had a torsion. The management would be, as we say, exploration. So literally opening up the testis, have a look, is it torted? Because you will be able to physically see that. And then they would essentially untwist it and fixate it. So that's called an orchidopexy. And so going back to the bell clapper deformity, because it is a bilateral thing, what they will also do when they're performing an orchidopexy for torsion is fix the other testis as well, because the risk of torsion in the contralateral testis, once you've had it once, is extremely high. It's like something up to 66%. So they'll just fix the other testis as well to avoid a representation. When you're discharging, essentially, it's about having the right discussions with the family. It's about what the actual pathology was, because often patients present emergently, they're rushed to theatre, and there can maybe not be as much time for the right kind of communication. So discuss with them about what a bell clapper deformity is, if they have one, why the other testis was fixated, etc. But those won't necessarily be conversations that you're leading as an F1. It's just something to consider. So that's torsion. Now, epididymo-orchitis, I mentioned that as a differential for someone presenting with an acutely swollen, painful testis, and epididymo-orchitis can make patients writhe around in pain similarly to how torsion does. So it can be difficult to distinguish, which is why we refer to urologists who see this every day and have much more experience in their armamentarium for distinguishing the two just based on the kind of clinical assessment. Again, a lot of the clues are in the history. So when did the symptoms start? Typically, epididymo-orchitis, you'll have a kind of slower onset of symptoms. Are there any associated symptoms that would indicate an infection? Because epididymo-orchitis is a reactive inflammatory process to some sort of infection. It doesn't have to be an STI, but obviously it's always important to ask about STIs, typically in younger males, but don't forget that older males can also get STIs. So don't kind of exclude that and think it's some sort of other infection that might be driving it. And offer STI testing if that's what you think might be causing it. They will typically have some urinary symptoms. So what to do? Obviously do a urine dip, send it off for culture, check their bloods. It will give an indication of, is there a more serious infection driving it? Should you be considering that there might be an abscess forming? Because that would also change your management. And you can think about doing an ultrasound as well if you're worried about an abscess or anything else that's underlying. When are these patients admitted? So basically, if they're unwell, if they've come to hospital multiple times, I mean, that counts for anyone really. If it's a second or third presentation with the same pathology is not going away, then do consider admitting them. If there are signs of an abscess, so signs of an abscess in duration, if there's a kind of hard swelling, the pain will be really quite severe. And again, if you've got these repeated presentations, then an abscess will be growing. If they're septic from their OBS, then obviously that would be a reason to admit. And if they're not improving, with a trial of oral antibiotics. Simple and uncomplicated epididymo-orchitis they don't need to be admitted to hospital, and they don't necessarily need to be followed up. But they need to be given the right advice about what to do. So safety netting advice and, how to help things. So they'll have antibiotics, simple analgesia, whatever's working for them. You can offer them a scrotal support that will help elevate the testis and keep them comfortable, but it doesn't always work. And in young men, think about do an ultrasound of the scrotum kind of in 4 to 6 weeks. So at the point where the inflammation should have resolved, if it is caused by an infection, to look for potentially a mast tumor that could be driving an inflammatory process. Okay. Phimosis and paraphimosis. So two quite separate things, but so phimosis is essentially when in males with a foreskin where it's quite tight, so it can't be retracted past the glands. It's a very normal thing in a lot of young children, but you also see it in older patients. I've seen it in older patients. A lot of people live their whole lives happily with a phimosis, but it can cause symptoms like painful erections, painful urination. Obviously, on our end, it can be more difficult to catheterize patients. And in terms of hygiene, it might make things more difficult because obviously you can't retract the foreskin. So for cleaning, it will be more difficult. A paraphimosis, on the other hand, is... So with the management of a phimosis, you can offer steroid creams to soften the foreskin. I haven't seen that used, but it's an option. But if someone is struggling with their phimosis, then essentially elective circumcision is the route, and they can be referred to urology for that. paraphimosis is when the foreskin has been retracted over the glands and for some reason has been left that way because someone has forgotten to return it to its original position. And you essentially get edema of the glands to the extent where you can't bring the foreskin back again. And this is obviously, this is why we always say when you do a catheter, always remember to retract the foreskin again, because the glands can become extremely swollen and it's horribly painful, and it becomes an emergency. The risk factors are a pre-existing phimosis, an indwelling catheter, poor hygiene, and a previous paraphimosis. When I've seen it, it's been in patients who do, for example, intermittent self-catheterization. So, they might just forget. They're frequently having to retract their foreskin, and they might have forgotten one time, and then they'll present with recurrent paraphimosis. The management, so essentially a manual reduction, it can be quite uncomfortable for the patient depending on how long the paraphimosis has been left. Dextrose soaked gauze, so that's kind of like a dextrose wrap. I think the jury is out on whether those actually work or not. I think typically people will just go for a manual reduction. If that doesn't work, then there's something called the Dundee technique, which I'd recommend looking up, but essentially it involves making some small holes around the edematous area, squeezing onto the glands to reduce the edema. This is done with a penile block, so with a good amount of local anaesthetic, because otherwise it would just be excruciating for the patient. And essentially then attempting the manual reduction again. If that doesn't work, then essentially they'll have to go to theatre for something called a dorsal slit, so an incision made into the foreskin that will kind of release that tightening, because there's a tight ring that forms, and that's obviously leaving them with a permanent with this slit in their foreskin. So we want to avoid surgery. And scrotal lumps, so again, something you'll see a lot of in A&E, and you'll become much more comfortable with examining them and distinguishing things to establish a differential. Hydrocele is essentially, it's a collection of fluid within the tunica vaginalis around the testis. So these are your sort of painless, soft swellings. They'll be fluctuant, they'll be transilluminable. So if you shine a torch through it, you can kind of see the light going through. You'll be able to palpate the testis. It won't, so basically compared to a hernia, it won't be reducible. It's not going to have bowel sounds. There are different causes of hydrocele. So a hydrocele can be reactive. So for example, in Epididymo-orchitis, you could see a hydrocele. But it can also be reactive to testicular cancer. So that's always something important to think about. Or you can have a communicating hydrocele where there's actually a communication into the peritoneal space. So you get peritoneal fluid going into this space. And that can be a cause of recurrent hydroceles. And those are the patients that will have an elective repair of a hydrocele, because it can obviously, even though it's not dangerous, it can have quite a big symptomatic burden. But reactive hydroceles would just be conservative management and obviously looking into any underlying cause. An epididymal cyst. So these are quite a common, but obviously can be worrying for patients because they might worry about testicular cancer. They're mostly asymptomatic. There'll be a soft round lump and you'll be able to get around it, so because it's distinct from the testis. And those will be investigated with an ultrasound and just conservative management, obviously safety netting if it worsens. If you are suspicious of testicular cancer, then considering tumour markers, ultrasound will also guide you down that route. Now, a varicocele is essentially a sort of engorgement of the pampiniform plexus, of the venous plexus, because of some sort of increased resistance somewhere. So, it's just like with other kind of vascular pathologies, it's a plumbing thing. They can be painful. You can have a sensation of like dragging in the testis. Subfertility or infertility can be kind of a secondary consequence of it. In terms of examination, it's this classic bag of worms texture, and it might, because it's due to venous engorgement, there can be a kind of pressure effect, so it will become more prominent on standing just because of gravity, and then it might ease on lying down. An important one for MCQs, but also actually in real life, we have seen, we do see this, because of the way the right testicular vein drains into the inferior vena cava, and the left testicular vein drains into the left renal vein. If you're seeing a left-sided varicocele, that can be because you've got a blockage in the renal vein, and that's decreasing the outflow from the left testicular vein. You don't have that on the right side. So when you've got a left-sided varicocele, think about a renal cell carcinoma that could be causing a blockage. So you can investigate varicoceles with an ultrasound Doppler. If there are worries about fertility, then obviously test their fertility with semen analysis, and consider hormonal tests if you're thinking about something like testicular cancer. Management, obviously there's always conservative options and surgical options. It depends on what the patient wants. Obviously, this would be something that would be a sort of urology clinic discussion. And you can also embolize the veins if it is causing a lot of symptoms. All right, so that was a lot of theory. If you do have any questions, we'll hang around for about 5 minutes, send them into the chat, or I think we can even message them privately. And our next session will be more on practical tips for an F1. There's a feedback QR code up in the corner. If people could give some feedback, that would be really, really useful. I'll hand over to Mohammed for any last bits.
No, I don't think there's anything. Like we mentioned, if anyone has any questions, then by all means feel free to ask away. Otherwise, we look forward to having you tomorrow for some more practical kind of tips. We'll go through some cases and just test you out on what you think you would do, what would be most appropriate in each scenario. So unless there's any questions, thank you everyone for taking the time out to join us. We hope you benefited, and we look forward to seeing you tomorrow. I'll give it 1 more minute, see if anyone has any questions, and then we'll call it a day. Fine. I think doesn't seem like there's any. Oh, is there a question?
Oh no, it's a thank you. You're very welcome. Oh,
Okay.
That's nice.
Okay, everyone. Thank you for your time, and we hope to see you.